on the screen, healthcare in between, physics, art, and math got us down this path. Historical tales come alive, where science and stories dive, blending facts with heart, knowledge from the start. Meet rich blues we sing, to the future memory. Health and science in the mix, Meadrick's got the fix. Complex subjects made
right
clear,
now
every episode
in ways that we actually acquire these
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is a truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hey, welcome to the MedBix Webcast. This is Raman Annamaraju. I'm the host. Thank you for joining. I have a very, let us talk about the heart disease a little bit. 1 in 3 adults is going to have a heart disease in this world. Okay? Can you believe that? In this country, in the United States, the highest cause of mortality is in the United States is the heart disease, heart attacks, and all those things. Half of all the adults in US have some kind of heart disease. That's a very 1 in 20 have a coronary heart disease. The cost of the healthcare in the heart disease is a $450 billion. Can you believe that? If we take that money, we put it someplace else, see that progress, that unimaginable progress we can achieve. So not only this, United States, India is the impending crisis in India. That's going to be disaster in making. All these guys sitting on the computer keyboards and sitting before the computers, they are putting weight. They don't have the mobility. This is the only anomaly compared to other countries. They said the statistics say that India is going to onset of heart disease in the early ages. That is scary. I don't know. There's no national strategy for India. I don't think so. We'll ask our guest. Let me introduce you. We'll ask him about the causes of the heart disease, the treatment, and the prevention. We need to ask all of that, all of those things with a very distinguished cardiologist. A good friend of mine is a Dr. Rakesh Sharma is joining with us from Florida. He's an interventional cardiologist. Let me bring you to the stage. Doctor, welcome to the MedBix Webcast, Dr. Sharma.
Ramana, thank you so much. It's been such an honor for the invitation.
Yeah, thank you. So let me ask you a question. You are author, speaker. You are very distinguished credentials you have, and you have publications, a lot of them. What do you think, with all your experience you have? What do you think? What are the things? Just give me your journey first, before your journey from India. How did you end up here in Florida? If you can give me that the professional thing a little bit, it helps us.
Absolutely, you bet. Well, I moved to the United States in 1983, and I used to teach anatomy in Georgetown University School of Medicine in Washington, D.C.
Really?
And, can you hear me all right?
I can hear you perfectly well.
All right. So after 1 year of teaching, then I got into the internal medicine residency program, which is a long process. I did Case Western Reserve University program, internal medicine. And after that, I was in Cleveland Clinic for a year, did some research there. I was a clinical associate. And after that, I did a fellowship in cardiology in University of Illinois, Chicago. Moved on to do an interventional fellowship in University of Missouri, Columbia, where I was then hired as assistant professor of cardiology. I stayed at the university as assistant professor of cardiology, did a lot of publication, a lot of speakership all around the world, and it was a wonderful experience. And I was also a director of the EP lab at Harry S. Truman VA Hospital. And then I moved on to Tampa, Florida in 1995. And I've been an interventional cardiologist since then here. And I'm currently employed cardiologist with the BayCare Health System as an interventional cardiologist. We have very busy practice, do more than 500 interventions a year. Very, very busy practice here.
Very impressive, sir. Very impressive. So let me ask you. So what is causing this? Is it heart rate, heart health disease? Heart disease is growing leaps and bounds in uncontrollable situations. Is costing a lot of money. What is it thinking it changed in the world? Your father time, my father time is different. We don't have this kind of a disease, pervading disease. Why you think? What are the causes you think as experienced cardiologist you are with the impressive credentials? What do you think in your mind? What are the things causing this pathal disease?
Well, that's a loaded question. I think you are absolutely right that cardiology or heart attack or death from the cardiac regions is an epidemic, and that's the leading cause of death. No, there are so many reasons. I can start from as simple as something you cannot change. That's your genetics. If you have bad genetics, that's a major risk factor. Like if you have very strong family history. Uh, Same way, that high cholesterol is a major issue. Some people have a very high bad cholesterol, and that could be a major factor. Some people have very bad lifestyle. They are smokers. Some people have diabetes, and all these risk factors can add up and cause problems, and people can present with a heart attack. And there's many ways you can prevent it, starting from the lifestyle modifications and taking care of self from the get going rather than waiting till the event happens. That's what is called primary prevention. There's a lot of focus on primary
Yeah.
prevention these
We
days.
we will talk prevention at the end if you don't mind, but let's talk about the diagnosis. How do you diagnose,
Well,
the heart problems?
right. That's a very important question, I think. I think everybody, and I think people very well know it, the heart disease or heart attack can present in many different ways. Now, typically, people will present with a chest pain, tightness, or there's a weight on the chest. And if this is bad, severe, and it's happening for the first time, you shouldn't ignore it. Some people may just present with shortness of breath. Some people, first presentation may be sudden cardiac death. Uh, so the presentation could be in many various ways, but one should not ignore any symptoms of chest pain. Especially in women, it can present in many different forms. It could be atypical chest pain, back pain, dizziness, shortness of breath. So if you have risk factors, and you should promptly think about it and seek medical attention. And once you are in the system, every community has an excellent system in place. Excellent system in place. Once you get to the emergency room or once you call your physician, there's an excellent system in place. They will take care of you.
So, what is the diagnosis? So, once you have how do you diagnose this? These are
So,
symptoms
so
you're
let's
talking
say
about.
let's
Let's
say
talk about
let's
diagnostic
let's take
devices.
let's take a scenario. Let's say somebody is absolutely fine, very healthy, and he has a positive family history that his father died at the age of 45. He's a smoker, has a high cholesterol, he's diabetic. And he's doing fine. One day at home, he's complaining of chest pain. He shouldn't be ignoring it. He shouldn't be calling it, well, it may be a muscle aches, it may be he was exercising, maybe it got muscle pull. No, you should pay attention to your body. If this is a new onset of chest pain, you promptly call 911 or seek a medical attention or call your physician. Once you end up in the emergency room or you get to the doctor, they're promptly going to do a EKG. Very simple thing. They're going to put some patches on you and they're going to run a EKG. An EKG can tell promptly if somebody is having a heart attack, what we call STEMI, ST elevation myocardial infarction. That is very important to know. I mean, yes, yesterday I did a 2 STEMIs. It makes a big difference. If we can take care of that patient within hours, all the muscle is saved. That patient will live a normal life. On the other hand, if you wait for several hours, if, for example, let's say the 6 hours are gone by, that muscle of the heart is permanently dead and you're disabled for the rest of your life. So therefore, new symptoms of chest pain, you end up in the emergency room or doctor's attention, they're going to do the EKG. Of course, we'll do many, many blood tests to especially called troponin that will confirm the diagnosis. But once we know that somebody is having an acute myocardial infarction or STEMI, they need help right away. It is not uncommon that I end up going to the emergency room to take care of these patients once or twice during the night when I'm on call.
Yes.
As of yesterday, I did 2 cases and
Yeah.
they did very well.
Amazing. Yeah, that is a cardiologist. Yeah, that's why I have a lot of respect because middle of the night you can go. You have to go. There is a call from hospital. Is a so the people who go to the ultrasound is also another CD. You do ultrasound to see what's
So,
going on.
Romana, so there's a many diagnostic algorithm. Depends what the patient is presenting. For example, let's say the patient come to my office, right?
Okay,
And
let's
the
talk about
patient
it.
is saying, well, I'm having a vague discomfort. He has all the risk factors like high cholesterol, diabetes, smoking,
Yes.
and we're going to do the diagnostic workup.
Yeah.
And let's say I examine him, and on examination, I find there's a new murmur, right? And then I do the EKG. It's kind of suggesting that maybe there was old heart attack. So this patient is having some symptoms of chest pain, has multiple risk factors. He's going to require some testing. So I may put him through a stress test. If he's able to walk, we're going to walk him on the treadmill. We do the myocardial perfusion study and
Nuclear medicine, right? Yeah.
nuclear medicine. And then since he has a heart murmur, I may do echocardiogram.
Yeah.
Echocardiogram is the ultrasound you're referring to.
Yeah.
Ultrasound basically can show all the chambers of the heart, all the valves of the heart. It can also show if the valves are leaking or if those are stenotic. So good history, patient coming to the attention of a physician. You do the basic workup, including some stress testing sometime, or ultrasound, which is echocardiography, some blood testing, lipid profile. We may do some special tests, lipoprotein related. There's many things we do, and that can lead to a conclusive diagnosis. Based on diagnosis, either we lead to the primary prevention strategy, and sometimes people had a heart attack already, then we need to focus on the secondary prevention so that he doesn't have a heart attack for the second time. So there's a whole different ways we pursue the patient workup depending upon what the presentation is.
If there is not an intervention is not required, just a preventive process,
Right.
that is, you came to your office, and then you find something, heart murmurs or whatever the high
Right.
cholesterol, high
Right.
glyceride. What do you do with that patient
So,
in general?
so this is a great question, man, and this applies to everybody. Remember, prevention is the best cure. If you can take care before you have a heart attack, that is called primary prevention. And who should be looking for primary prevention? That is an important question. Well, anybody who has multiple risk factors, let's count it. For example, you have a very strong family history. For example, you have a very bad hyperlipidemia, or you're diabetics, or you're a smoker. So those are the patient need to seek some primary prevention. I will give you one of the simple tests we also do these days is, which is very popular. I actually published a paper in 2010, about 15 years ago. It's very simple. It's called coronary calcium score. And a lot of people, actually patients ask me these days, doc, can I do a coronary artery calcium score? And basically what they're asking is, do I have any plaque buildup in my arteries? They have risk factors like diabetes, high blood pressure, high cholesterol. And coronary artery calcium score is a very, very simple test. You can walk into the CT scanner in your street clothes. They put you under the scanner and literally take less than 5 minutes of room time, and all of a sudden you have images which they can give you a score. Your score could be 0, your score could be up to 100, it could be 100 to 300 or more than 400. That all tells us indirectly that how much plaque burden is there. And if the score is more than 400, sometimes the probability of significant blockage is very high. So this patient is totally asymptomatic, but he comes to the
But
attention and he wants to do
but
the
yeah,
primary prevention. This is one of the way we can also look at. But
that's the
there's
most
many other ways.
99% of the people. What about athletes? They have this build up because of they put the muscle into the, so it's like a paradox, right? And in the athletes, in that you may find a lot of calcium on their arteries and then coronaries. What do you think of that? That how do you, a lot of kids die while they're playing football? What do you have you seen
So,
that situation?
so those are
With
two
the,
different things. Let's separate out both things, different things. Number one, let's talk about the athletes who can die on the court while playing.
yeah.
That sometimes could be a genetic disorder. That probably has nothing to do with the calcium buildup in the
Okay.
arteries. Those are sometimes people have what is called hypertrophic cardiomyopathy.
Mhm.
So it's a genetic disorder. And if let's say it's not screened, that's why these days when they get the athletes, they will do the ultrasound, make sure they don't have hypertrophic cardiomyopathy. There are some people have a history of sudden cardiac death in the family, right? So those patients we want to make sure they don't have any congenital abnormalities, like for example, long QT syndrome, some genetic disorders
Okay.
predisposing to sudden cardiac death. So you make sure and you before you clear them for competitive sports, you look at those basic things, especially with the family history. No, you said how do we should we screen for a like plaque in the arteries? No, drinking proteins or calcium in the drinks has nothing to do with that. Let me explain to you what calcium buildup in the arteries all about is.
Mhm.
When you're born, you have a normal looking artery, okay, normal intrama, but it's just like a pipe. As the wear and tear happens, the plaque can build up. But the thing is, if people have multiple risk factors like diabetes, high cholesterol, smoking, then they can build up the plaque more sooner in their life. And sometimes those little plaques can rupture and heal, and eventually they get calcified or fibrotic. So once you start seeing some calcified plaque, you already have gone too far.
Mhm.
That's why people are totally asymptomatic. And when we do a calcium score, depending upon what age it is, sometimes the score as low as 10 in a young person who is 40 may be very important. But at the same time, Ramana, if somebody, for example, let's say somebody older than 80-year-old, and I do a calcium score on him and it's a 0, well, all of a sudden I can say, well, there is this patient is probably not going to die of the heart. They can possibly may die of cancer. So
Yeah.
it works both ways. So it's called warranty of 0. If somebody's calcium score is 0, way in an advanced life, maybe that's also very reassuring. Uh, so so I think I answered your question in two different
Let
ways.
me ask you, calcium scoring, still you have to go through a CT scan. Nowadays, sometimes insurance company may cover, may not cover. So
Right.
what about the ABI index, PAD, peripheral artery disease? Can
So,
you recognize our cardiac symptoms through the PAD testing ABI index?
right.
Ankle break index, you can do running. Is it possible you can screen a lot of people? That's the cheapest test, non-invasive test, easy test. What do you think of that?
For the heart or for the peripheral arterial disease?
Peripheral arterial disease, but it can also indication to the heart disease, is not? ABI
Right.
index.
Sure,
Yeah,
sure.
chlorosis
Well,
decreasing
I
across.
think especially if people are complaining of some symptoms of peripheral arterial disease, such as, hey, I can't walk. Every time I walk, my legs are hurting. As
Yeah.
simple as just measuring the blood pressure in the legs, what is called ABI index. Very simple. Then the
Yeah.
ABI index can give a indirect suggestion that there may be blockages in the arteries in the leg. Yes, you're right. If you have a peripheral arterial disease, there could be a probability because atherosclerosis is a generalized process.
Yeah.
It affects the arteries in the legs, in the abdomen, in the brain, as well as in the heart. So once you have atherosclerosis at one place, you at least should review all the systems.
All
Is there a
this.
possibility of having a problem some other territory and screen it appropriately as needed?
So that is another good test in India. So, for example, the large number of people in India, they may not be able to access the CT scan, but you can access the ABI index. They can.
ABI is very simple. You put the blood pressure cuff around
Yeah.
your ankle, the blood pressure cuff in the here in the arms. You can compare it, and it give you the ABI. And normal ABI is close to 1, and if it's diminished, and you get a direct idea that there could be a possibility of peripheral arterial disease. No, you are mentioning about the CT scan. The CT scan is different. Now, remember we talked about coronary artery calcium score. Coronary
Yeah.
artery calcium score is very simple. In fact, the radiation exposure is minimum, 1 millisievert, very minimal exposure. Living on this planet, Ramana, you get 3 to 4 millisieverts of radiation every year. And if you fly all the time, then your radiation exposure per year goes up. So what I'm
Yeah.
saying is, I'm trying to give you an idea that
Yeah.
screening with coronary artery calcium score is a minimal like 1 millisievert. Now, if you do a coronary CTA means you want to look at those arteries.
Arteries, yeah.
And they
That
will
is a
inject the dye and they take the pictures of the heart. And that's about, could be prospective scanning, could be done in 6 millisieverts or even less, much less. Even, and that can tell you whether there's a stenosis or something needs attention. If there's a negative coronary CT, I mean, no blockages, has a very high specificity. So that's
Dr. Sharma, my thing is, how do we give access to large number of people with limited resources? You know that we have a butterfly, new technology is coming up, AI is coming up, so you can measure you can count that calcium scoring much easier. And then what about the butterfly, that kind of thing? There is a one close to my office here is exo imaging is similar to the connect to the iPhone. So these are all new modalities. You can check in India with a massive population like that, or Africa, any other place. You can check these. You can easily, even in the United States, rural areas don't have all these facilities. You think that this training, this kind of a new technologies will help?
Well, I think the screening of coronary artery disease will basically start from screening for simple things, the risk factors, screening for a blood pressure. Then you look for it as simple as coronary artery calcium score, and and then based on that you can do some other testing. But yes, as simple as radiologists read all the time these scanners, and there's a
Yeah.
calcification on the arteries. Patients didn't even come for that, but they can look at that. The arteries around the heart are calcified, and they can actually grade how bad that calcification is. Even from that, they can do the interpretation that this patient should be further evaluated by a cardiologist. I think awareness, Ramana, everything begins with the awareness. If
Yeah.
you have awareness campaign for heart disease, then people will start thinking about simple risk factors, which I have mentioned so many times. And then people start modifying their risk factors. How many people know that what's my cholesterol is?
Yeah.
Let me tell you something very funny. I will a lot of time trump my lot of my colleagues and doctors. I will ask a simple question, and I will ask you that too. Is there any good cholesterol and bad cholesterol?
Yeah, that's what
Everybody
we
will say,
think.
yes, there is. But then I will say, no, 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 there's no good and bad cholesterol. All cholesterol is same. You can
Okay.
trump most of the people, you can ask that. So The cholesterol is always same. Remember, your body is made of cholesterol. Every cell you have in your body, the membrane is made of cholesterol. You with me?
Okay.
So if your membranes are made of cholesterol, how it could be bad? So there's no good and bad cholesterol.
Very
So people
interesting.
have to further qualify that statement.
Yeah.
When you say LDL cholesterol or HDL cholesterol, yes, then you can say, yes, LDL cholesterol is bad, HDL cholesterol is bad. Just imagine this cholesterol is like a fat, right? That has to
Yeah.
travel in the blood from one place to other place. Maybe, for example, let's say brain needs it, liver is making it, it has to travel to brain. How does it travel? Put a fat in maybe some media of water, it cannot travel. It's not water soluble. So that means that fat, that cholesterol has to be encapsulated in some lipoproteins. And then the proteins, and that's how it travels from one place to other place. If those proteins, those lipoproteins are LDL, low density, that becomes a bad cholesterol. If those are high density, that comes in. So therefore, you can't say there's a good cholesterol and bad cholesterol. Cholesterol is the same. It is the company it keeps. It is the
Yeah.
company it travels. That makes
Yeah.
good or bad cholesterol. And so it's very, very important. So the people need to know what is their LDL cholesterol, what is their HDL cholesterol. Even one more thing I will tell you in Indian is very important, more prevalent in Asian. There's one kind of cholesterol called lipoprotein little a. It's a
Yeah.
lipoprotein,
I was
just like
about to ask you that.
LDL,
Yeah.
HDL, no, the lipoprotein little a. That is very atherogenic. Everybody should check their lipoprotein little a one time. Do you know what yours is? If not, you
No.
should check one time at least. So if
Okay.
that is very high, we'll need some, they can become a risk enhancer, and sometimes you got to think about it. So
Mm.
So to answer your question, awareness is very, very important. As simple as knowing your blood pressure, knowing your cholesterol, be aware about your family history, knowing how much smoking can cause damage. Diabetes is very bad. You all these once you have awareness, then you go to the next level. Do I need a primary screening where I can do a primary prevention? Because there's so many good things you can do in primary prevention, starting from the diet, modifying the risk factors, and then of course doing some further diagnostic testing.
Let us talk about obesity. They say the cardiac disease is connected with the obesity, but I see anomalies a lot of times. Gujaratis, for example, they're very thin, but they have the highest, they have the one of the highest cardiac disease. So, how do you define this? This is a myth that they have. If you are obese, automatically your cardiac disease, or is it obesity is one of the factors or one of the major factors? What is obesity plays a role
So
in cardiac
okay,
disease?
so that we can almost spend an hour on this topic. Obesity clearly is linked with the heart disease, no question about that. But obesity, a lot of time they may have hyperlipidemia or they may not have. You are correct that some people are very obese and I will do a heart cath and their kidneys are absolutely clean. That's a different thing. But I think obesity predisposes to many things. Let's list those. Number one, obesity predisposes to high blood pressure. Number two, predisposes to diabetes. These people often don't do much exercise, and if they're very obese, sometimes it can predispose to respiratory distress. They can breathe properly. Uh, so obesity is a basic, and you can exercise properly. In fact, this is the single most important risk factors you can modify. And a lot of times, Ramana, it is the portion control too. Yes, some people are predisposed to be obese, but it is your dietary habits. It is what kind of diet you eat. It is how much activity you do. It is what is your portion control. Uh, all these factors matter. And I
What?
tell them, I will tell my patient, And when I tell my patient, hey, you got to lose some weight, and he said, okay, I got my membership in the gym already. I said, well, that's not going to work. The first thing is pay attention to the food. All right.
Yeah.
Membership will come later on. You can
That's it.
exercise all day, and if you don't modify your dietary habits, you will not see results.
Yeah.
But obesity epidemic is a major problem, and it leads to metabolic disorders, mainly involving the diabetes. Then, of course, can have a dyslipidemia. Then that can predispose to plaque buildup. Plaque buildup can lead to the heart attack. Heart attack can lead to the death, and then you get into this vicious circle. So, therefore, I say obesity management is very, very important. And this is an important metabolic disorder. We can't
Yeah.
just say it is a simple, only dietary issues. It is a lot more than that. It's a metabolic disorder.
Is it possible that new drugs are coming up, like Ozempic,
Yeah.
GLP-1
So,
drugs? There are new things coming up, these messenger drugs. So,
absolutely.
what is your take on that?
So this is a wonderful, wonderful advance in medicine has happened, the semaglutides. There are many, many semaglutides. Ozempic is one of them. Manzaro is another one. Wegovy is another one. So yes, these are very, very good drugs. In fact, Wegovy has been approved for management of reducing obesity in people with heart disease because it was shown that it reduces the secondary MIs or heart attacks in those patients.
What they
Those are
do
very good
exactly?
drugs. And
What they do,
I personally are a proponent and in favor of that, but it has to be given by a physician under their direction.
what they do, they stop eating, less you eat. Is like a
So,
messenger kind of thing. It stops sending messages to brain. Is something suppressing the hunger, or what it does?
so it is a multifactorial. So
No.
remember, I told you that obesity is not only a dietary, it is a metabolic disorder as well. Clearly, this will
Yeah.
decrease the appetite. Once you will not eat enough, that is going to, but it also works at the level of the metabolic and the cellular level, and where it can uh, work favorably, where your consumption of calories is more, uh, and, uh, and then the weight can go down. So I think it's a multifactorial. But yes, you're right. One of the major factors, appetite does go down. That's why people do have some side effects, GI side effects. Uh, I'm not expert in that area, but I think I am a strong proponent that if any of my patient is morbidly obese, and if they have coronary artery disease, I have no problem prescribing Wegovy. But if I think otherwise, if they need Manjaro or Ozempic, I will tell them let's either refer you to the obesity clinic or let's refer to a person who is expert in that, who does this for a living.
There is a long tradition in India, food as a medicine. It came from Ayurveda, right? So, what do you think on the food as food plays? What kind of role food plays
Well,
in the health wise and the cardiac, preventing the cardiac diseases or any
well,
disease in?
food has a huge role. As a matter of fact, food is one of the medicine. If you eat
Yeah.
right food, things will dramatically change. The problem is, it is we don't eat right. We don't eat in right proportions. If your lifestyle is such that you're going to be always on the go and you're going to always be eating fast food, and that's what you're going to get. But if you eat a healthy food, and there's healthy food is available in every society, it doesn't matter. It could be Indian, Chinese, Mediterranean, American. You could take examples of just Indian, for example. If you want to eat a healthy food in Indian, you can eat a wheat, all right, grain, right? You can eat,
Paneer?
yeah, you can eat paneer. I tell you, the definition of you shouldn't be eating too much saturated fat. I sometimes give a very simple example to patients. Sometimes they don't quite understand what is saturated, what is unsaturated. I tell
Yeah.
them
Tell
any
us.
fat solid at room temperature is
Yeah.
saturated. So pick up your anything which is solid. You pick up your butter,
Gee.
you pick up your margarine, but anything which is not solid at room temperature, now you pick up your oils, those are unsaturated. So I will tell them maybe utilize those. Don't utilize too much saturated fat. No, all red meat is a saturated. Uh, so diet plays a huge role. As a matter of fact, the people who eat vegan, for example, uh, I mean, diet is a whole issue. I mean, some people will say, well, I want to be carnivorous. I will do very well. But if you eat a balanced diet with balanced amount of carbohydrates, proteins, and you have a good control on your portion control, you will do very, very well. But there is
What about
options you have. Sorry, go ahead.
the lifestyles? A lot of people are Atkins diet. You have all these diets. New diets, Martha Stewart diet. These are
You
all
can
fads, or really, or do they make
no,
sense
no,
at
no.
the end?
So you can deal with your metabolic things any way you wish, you know. But I tell you, if you are going to do some strategy which is only going to work for 3 to 6 months, that's not going to last long. You've got to have a strategy which you're going to enjoy, and it should be lifelong. You should be able to. If you can only diet for 3 months, okay, well, I'm going to start doing intermittent fasting. I'm going to start doing Atkins diet. I'm going to start doing carnivorous diet. Well, are you going to do that rest of your life? Probably not. So therefore, that's why I will say, you adopt a diet, a healthy diet,
They
and
don't do
stick
that.
to it, and also enjoy it. And if you stick
Yeah.
to very simple principles, you generally do very well.
Yeah. That's a great advice. A lot of these people think that, yeah, you're absolutely right. They don't do lifelong. They do like 30 days or 60 days or 90 days, and they go back to the
Go
original
back. I mean,
problem.
I've seen patients, they do the semaglutides, these new semaglutide. They go for a special clinics, and they get once a month. I mean, it's amazing how the thing.
Yeah.
And but it depends. You want to look good in the next 1 month, and then maybe after that it doesn't matter. But I think if you modify your lifestyle in such a way that you're going to eat right, you can always cheat here and there. You're going to eat right most of the time. You're going to have your exercise program. You're going to do your meditations. All right. And if you add everything, you will generally would be healthier. The problem is the life is so busy. People are on the run all the time, and they forget about it. Uh, and you said it very well. Food is actually one of the best medicine, but if you eat it right.
What is your take on the intermittent fasting, Upawas? India, my mother used to do Upawas. I do intermittent fasting every day. Actually, I don't eat 14 hours. I drink a lot of
It works.
coffee.
It works. It works. There's
It
a
works, right? It's
there's
really
a
amazing.
it works. I mean, there's nothing wrong with that. Uh, in the remote past, when there was not abundance of food, and this is how it used to work. You eat and
Yeah.
store, and then you're fasting for next 14 hours. You know. So
That's what I do every day now is I'm using for it.
I
So easy to do it. Actually, it's not that difficult. People think.
no, it's not difficult. I mean, I think so. I think in a diet itself, Ramana, for example, is a huge issue. In our cardiology specialty, if I have to give a dietary consult, I will give the basic spiel in my office. But if I need to do a detailed dietary consultation for an hour, then I'll send it to a dietitian and then have a whole lot of discussion. Then figure out what exactly you're eating, what changes we need to make, because it is not a simple conversation. You actually need to investigate what patients' habits are. A lot of times you would be surprised, patient doesn't know what they're eating. They wake up in the middle of night, they go up there to the fridge, they open it, they eat, they don't forget. Sometimes I would tell my patients, put your snacks high up. So you have to make an effort to grab it, not just sitting at the table and there you're taking a bite and you're gone. You don't even remember sometimes. Uh, these habits are very important. Uh, and I think uh, if you're not able to lose weight, you need to investigate in detail. I was giving you an example. There was one of my patients, he was a judge, and he's sitting most of the time taking care of the cases like, and he was so overweight. And they did everything possible and couldn't figure out why he's not losing weight. And he was doing everything right. But then I said, well, let's start from the day you leave from your home to the court. What do you do? One thing he never told me, he take a jug of water and puts a lot of sugar in there. And all day he drinks a little bit of that. I said, well, there you go. So
There you
sometimes
go.
you don't even realize what people are sometimes eating.
Yeah.
Sometimes
There
they
is-
themselves don't realize. Sometimes you have to the calorie count. It's amazing. But yeah, the complex dietary consultations, I will then send to the dietary specialist. Let them have a conversation.
So you wear another hat, which is the president of American Association of Cardiologists of Indian origin. The word is I attend all your conferences. One of the really doing well. Last conference we had a great time and fun, and he conducted beautifully well. It was really exciting, and it is entertaining, and it is informational. And one of the where I met Nathan Wang, and he was talking about LP proteins. You gave a lot of lectures. It was a really educational, and then you inspired a lot of young people to pursue cardiology. Tell us a little bit about the mission of, as a founder, is Dr. Navin. Nanda is one of the greatest cardiologists, one of the well-known cardiologists in the world. So,
Right.
what do you think that role of American Association of Cardiologists of Indian origin?
Right. Well, thank you for bringing it up. As you know, I'm the current president of AACIO, which is American Association of Cardiologists of Indian origin. And this was founded in 1986 by Dr. Navin C. Nanda, who is not only well known in USA, he's well known around the world for his amazing contribution to the science. And he's currently is our chairman of the board. So we do two programs in conjunction with the local societies, local Indian societies, and and we really actually also appreciate your support. You're always there and always introduce us to the many important people. So American College of Cardiology and American Heart Association. For example, our next program is in New Orleans, American Heart Association, and we will have some leading speakers. We do excellent programs, cutting edge program. We also have one of the thing is young investigators. Young investigators will bring their original research and they will present it. We'll give them an award. We have given a total of 93. We have honored 93 young investigators so far. Some of these young investigators have gone on to become world leaders and
Hmm.
thought leaders. So I think this program has been going on for a long time.
Long
Uh,
time.
American Association of Cardiologists of Indian region working closely with American College of Cardiology. As you very well know, American College of Cardiology announced a award, Navin C. Nanda International Service Award in perpetuity, which is a wonderful, and that's the award would be always there. And AACIO is the sponsor, is right behind it. So AACIO is doing a lot of things. We want to bring our well accomplished uh, physicians of Indian origin and get them recognized by these larger organizations like ACC and AHA. Um, so I think next program is in New Orleans, and hopefully we'll see you there.
Yeah. What about ACC, American College of Cardiology? They're doing a lot of fun. Do they work? Do you work with these organizations, the major national organizations? Do you work American Association of Cardiologists of Indian origin? Do you work closely with these major national organizations?
Yeah, we as much as we get opportunity. For example, last year you might have noticed I have worked with the American College of Cardiology for the whole year as we were going through to get this award set up for Dr. Nanda, which is Navin C. Nanda International Service Award. It was a long process, and there's many meetings, and then we finally established this award in his name. And ACC will do they have established various communication how they're going to advertise this award worldwide, because people will have to apply for it, and then they have to compete for it, and it is an honor if somebody would be getting this award. Remember, Dr. Nanda himself got that award many years ago. That time it was not called Navin C. Nanda International Service Award, but it was International Service Award. So we work with we've been working with the American College of Cardiology on this aspect. Same way we will work again. Let's say we want to recognize another leader, and we will make that initiative, go to the board first, and then make a proposal. We present to the ACC again, the meeting starts, and once it's recognized, it's a long process, Ramana, though, but it was an honor. Yeah. And last year, as you noted, Dr. Nanda has been honored by ACC very well, and we are thankful to them. And if you notice, a president of the foundation, Ms. Bryan, she came there, she gave a little lecture on behalf of the ACC president. So that was quite an honor. So we'll work closely with them.
Nanda, because his Kenya travels, I was so impressed. He was talking about his life in Kenya and how his father was inspired him, and how he went back and forth in steamships. It is really taking to a different world, in fact, different conditions in the world. I mean, I was so integrated by his story, and it's a fascinating story that we want to tell the world, actually. Dr. Sharma, I want to ask you.
We are thinking of establishing some scholarship. One of me and Dr. Nanda was talking the other day. One of our goal is also to help physicians who come from India and they need help. Sometimes some people are not very lucky. They need introduction. They need to be introduced. They may be very bright, but they don't know the system. And so we would be going out to the world, collecting maybe 10, 15, 20, $25 donation kind of thing. And so we want to plan bigger things. The goal is to help who needs help. Of course, we want to recognize the leaders, but we do want to help the people who needs help.
Dr. Sharma, one thing I want to ask you, different, I am with Dr. Japra, Ramesh Japra is here. He is a very religious. He started a temple here. You also started a temple, Sanatana Dharma. That. What is Dharma? What is a beauty? What is spirituality does for your body and health and the mind? Can you give us a little bit about that background, a little bit more? And
getting out of my little territory, but I will. I love Dr. Ramesh Japra. He's a great guy. He really is. We talked to him together. Remember when we were at American College of Cardiology? I think spirituality is huge. Remember, I was telling you that Sanatana Dharma, of course, basically encompasses all the dharmas. Like if you come to our temple, it's a very unique temple here. You will see every single murti in our one temple, from east to west, from north to south. Yeah. And so, but the core really is, I believe, if I'm not talking about from scientific perspective, meditation is proven to lower the blood pressure. It's proven to help you sleep, but that's from medical perspective. But if you really go to a Indian spirituality, which I am not quite qualified to comment on that. I am a chair of all the trustees in my temple. But that does not make me qualified to comment on that. But I do know that, there's so many gods we worship, Lord Shiva, for example, Rama, Krishna, and they have been the, in our life, there's so many stories. Uh, but Indian spirituality is very rich. If you think about Ramana for a second, Krishna story, it goes 5,000 years back. So you have to go back many thousand years before BC, before Christ. And if you go to Ramayana, that's a 7,000 years. So, and the Hinduism is a very rich and sometimes is not well understood.
Yes.
And I hope, and one of the reasons of Sanatan Dharma, the temple like this, is to perpetuate the information to the young generation, which is very difficult. I must admit, I don't go to temple much. Yes, I am a chair of the trustees, and I do all the meditation I do for health reasons. For example, if I can't sleep well, I will have some mala in my hand and I will meditate and you go to sleep. That basically means you're using spirituality for your health.
Dr. Sharma, you are one of the institution in the Tampa Bay area. Everybody knows you. You are. What is your legacy? You want to do? What do you want to tell the world? What you want to leave a mark on the in the cardiology side or your spiritual side? Which one? Where do you want to leave the
Well,
mark? I'm saying that you're. I want you to continue to live a long years. You and Dr. Nanda for a long time. But there is.
I definitely like, people always ask me, when you going to retire? I say, I just started. I'm not going to retire soon. I think I get my, somebody said very well, when I go to hospital, it's like my cup of coffee. I enjoy it. People should only work as long as you love it, because the moment you don't love it, you will not do a very good job. Then you should seek for your retirement. Um, I love to do some research. In fact, I will tell you, one of the research we're doing here is we are probably only two centers in Florida. It's called stem cell therapy in the heart. If the heart muscle is so weak, no medication is working at all, you're left with nothing. We are doing a trial, and in fact, I enrolled the first patient on April 29th. It was released in the news, and basically what we do is we take the cells from the bone marrow, spin it, and then basically put it on the table. We go inside the heart, and there's a special delivery catheter, and with a screw at the end of it, and we deliver those cells at 10 different sites. Now, this is a randomized, controlled, very high standard trial. We don't know what the results will come out. But yes, I love it. I love it because it gives me yes, we all want to practice our medicine, take care of the people as come with a heart attack and so forth. But research is also something unique. And I do enjoy that. Uh,
You're always, I know you for a long time. I know one thing you love is technology and artificial intelligence.
right.
Let me ask you, you always ahead of, even though you're a traditionalist in the clinical side, but in the technology side, you embrace it full way and you jump in the front, So tell us your experience on the
That's
basic
it. That's a
technology.
good one. I like it. In fact, right now, currently as we speak, I am a student of Harvard Medical School. I am doing a course which is called Artificial Intelligence and Medicine. So I am on, I think it concludes next week. Was pretty amazing to learn about that. I believe technology is very important. I think the patient care is very complex. You have only so much little time. You will need technology's help to deliver a best care. There's no question about that. There's actually I sort of helped founding one of the company called Coligomed, and even we did about 99 myself and one of my local friends, Mr. Taneja, we launched a digital health revolution that time. And there was nothing there. So I'm always,
Yeah, I remember that.
I'm
Yeah.
always thinking to do some digital health revolution. And I think this one, what we're trying to do now, I think it's going to do very well because artificial intelligence is a bigger part in it. How can you take care of the patient when the patient is not with you in the office or the patient is not with you in the hospital? Patient is out there at home. How is taken care of? There are so many devices that are available these days. There must be a way that patient is monitored, and we should get an alert that patient is not getting in the right direction and get triaged to the right person. I believe artificial technology is going to help big. Artificial intelligence is also going to help a huge time in the research. For example, if I have 100 papers sitting on my desk, it will take me months to go through that. With artificial intelligence, it will happen in minutes. That's where artificial intelligence is going to be huge, and I think it will make a big impact in our time. It will make a bigger impact in our time.
That is
And
Sharma, your wisdom, your academic background. We need all the your good blessings. We all need everybody, all the young cardiologists, young doctors. You are a treasure for all of us. Thank you so much for joining with us. So, if you want to give a final word, just please go ahead and tell me. Thank you so much. This is truly an honor and a privilege to have you on the podcast.
well, Ramana, first of all, thanks to you, and you are also an amazing guy, and you're very humble. Let me tell you, you're so humble. It's amazing. Me and Dr. Nanda really love you, and you try to help our AACIO in many different directions, and we recognize it, and you go out of the way to help out our organization, and we truly appreciate it. I truly appreciate you bringing up a lot of issues, a lot of little issues. Every issue matters for the patients. Patients need to understand what they need. They need to recognize, be aware that this is an epidemic. They need to be aware what they can do about themselves. They need to be aware what are the primary prevention strategy available. They need to be aware they don't need to get to the point where they have a heart attack. And there are many ways to help themselves. And there's a lot of education is available. And AACIO is also doing their part. And once again, I thank you very much and look forward to talk to you more down the line once our research trial on the cell therapy is over. Let's see what it comes out of it.
Thank you, sir. Good night, all of you. Thank you, sir. It's an honor to have you.
Good night.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.